Hi, I'm Dr. Christina Blanchard-Horan, Principal at Global Health Liaisons and founder of HIV COVID Talks. I'm here to introduce this platform, HIV COVID Talks, starting with HIV Then and Now, where we reflect on the history of HIV and to introduce COVID as a new situation that needs to be addressed. The series HIV Then and Now explores the history of HIV and compares that with the current situation with COVID. This series is dedicated to Dr. James Jita Hakeem, an HIV/AIDS researcher who was there at the beginning of the HIV epidemic. He and his colleagues started the very important study, the DART study.
Well, I think it was really a coming together of minds. There were many researchers and doctors interested in treating patients with HIV and AIDS from Uganda and from Zimbabwe. There were other people from the UK and some from the United States. At the turn of the century, it became clear that antiretroviral therapy was really important to stem the deaths and the severe impact on health that HIV was exacting. So doctors working with HIV and AIDS patients in Uganda and Zimbabwe met in 2001 in Harare to consider ways of how best to give antiretroviral drugs to the vast number of patients who require treatment. One of the biggest issues was laboratory monitoring. Laboratory tests in the West are done on a very regular and routine basis in patients who are receiving antiretroviral drugs. And there is really no firm scientific basis to this, but in Africa it became an obstacle for a number of reasons. Number one, laboratory tests are obviously costly. Besides, you would need to have laboratories which were capable of doing these tests spread all over the place, and clearly if this was a requirement and if we needed to do routine laboratory tests with the same sort of regularity as in the West, it would be impossible in the African scenario, given that laboratories were not available in rural areas or smaller towns, and this was very frustrating. And this is how the design of the DART study was conceived. The results of the DART study are exciting. They show clearly that patients who are monitored by well-trained staff, doctors, nurses, and counselors, can give drugs and achieve outcomes that are as good as patients who are monitored very intensively like those in the West. The availability of laboratories is still a big obstacle today. DART shows it's possible for patients to receive their treatment in rural areas on a regular basis with very positive results as far as resistance is concerned, and also achieving a high number of patients on treatment.
And now, without further ado, let me introduce Dr. Linda Sagristano. Dr. Sagristano is an applied social and community and health psychologist with over 25 years of research experience, including HIV behavioral surveillance and prevention in the United States. She's the moderator of our HIV COVID Talks panelist discussion today, HIV Then and Now.
Thank you, Christina. It's a real pleasure to be here. And I want to welcome our panelists for today and thank them for being here. So before we begin, let me take a minute to explain the format for today. First, we have pre-arranged questions for each panelist. Each panelist is going to have 5 minutes to respond to their questions. This will be followed by a panelist group discussion about the future of HIV and COVID. Finally, we will open the floor for questions from the audience. Our first panelist today is Dr. Peter Mugeni. He's the president of the Uganda National Academy of Sciences, and he's a physician, a research scientist, and founder and former executive director of the Joint Clinical Research Center, or JCRC, in Uganda. He's the author of several books, including Genocide by Denial, which was published in 2008, and A Cure Too Far, published in 2012, which are about the HIV/AIDS epidemic. He was also featured playing himself in the movie documentary Fire in the Blood. Peter, in your books and the documentary, you describe the first days of the HIV/AIDS epidemic. What are some of the highlights from that time, and what are the similarities to the world's response to COVID today? Is history repeating itself?
So that history here is repeating itself, and we are hoping that the lessons we learned from HIV/AIDS could apply to COVID epidemics as well. The lesson we learned was that preventive measures, which include treatment and the usual preventions, are highly effective, and HIV now no longer kills people en masse. In the case of COVID, we know preventive, like in HIV, preventive measures, using standard SOPs, masks, social distances, and so on, combined with vaccine could be effective. So this lays out a background in brief, which we hope we can discuss further with the audience as questions arise. But this was the situation that clearly applies and is mirroring each other in HIV epidemic as well in the current pandemic of COVID-19. Thank you, moderator.
Thank you, Peter. Actually, we want to come back to that issue of in lower income countries when we have our group discussion. So thank you. Okay, next we're going to turn to Dr. Diana Gibb, or Di. She works with Drs. Hakeem and Dr. Mugeni as they began organizing what would become the DART study, which was mentioned in the video. She's a professor of epidemiology and a pediatrician at the Medical Research Council Clinical Trials Unit at the University College London. And she's a senior member of respiratory infections and on syndromic infections. Di specializes in HIV. Okay, so she is a founding member of PENTA, the Pediatric European Network for Treatment of AIDS, and she's set up and undertaken a wide network of late phase trials and cohorts across Europe, Africa, the Americas, and Asia. And she initially focused on pediatric HIV infection, including TB, malaria, hepatitis, and now COVID. So what I'd like to ask, I'm going to ask Di 2 questions. The first one is, how are children who are living with HIV being impacted by COVID today?
Thank you very much, Christina and Linda, and to all our panelists and participants. Just before I answer that question, I just want to also extend my remembrance to James, who with Peter and I was at the same small meeting in Zimbabwe where there was no treatment for HIV, and we first conceived ideas about the DART trial, which you saw that small clip of James talking at. And the other thing that I think James did, and also Peter, who's a pediatrician, in fact, was to really think about children. And there is a difference here, because for children, HIV was quite devastating, in fact, and many kids died in their first year of life. And in fact, I did a study before there was antiretroviral therapy, looking at a simple antibiotic, cotrimoxazole, in Zambia, and whether that would help. And it did help children, but nothing like antiretroviral drugs, as Peter has described. But what was interesting about that was that a lot of people said these children die long before you even know they're infected. You won't find any children. And it was quite a big study, but the average age of the children was around 5, but nobody was testing for HIV in those early days. And James and Peter were very involved in not only the DART trial, which you heard a little bit about, but the trial that followed, which was called ARROW. And in fact, I think James coined the name of it, which was antiretroviral therapy for watoto, which is a child in Swahili. And so not only did we have, researchers on the adult side, but also the children's side who grew together, because this was a family disease. And of course, COVID also affects families, but there is a very big difference. Children who get COVID very rarely get bad effects from COVID. So I know this from the UK and other northern countries. I mean, there's been rather few deaths. Hospital admissions, only about 1 in 100,000 kids who get COVID are admitted to hospital. And the reasons for this, people don't really fully understand, but it may be that one of the things that makes you sick from COVID is the immune response to COVID. And in fact, age is one of the most important predictors of getting bad COVID and this immune dysregulation with COVID. So the older you are, the more badly you can be affected. So young children are very often asymptomatic. They get the infection, they can transmit the infection, but they are rarely very sick from it. They have described a syndrome called PIMS, which is a post-infection inflammatory syndrome in children, but again, it's very rare, and it doesn't usually certainly kill children. So basically, the effects of COVID on children, in many ways, I think, have been the effects of the response to COVID. So, for example, where you've got lockdowns, then you have late presentation of other diseases. So for children who get acutely sick with meningitis or even tuberculosis, we have good evidence here that these kids, when you've got lockdowns associated with waves of COVID happening, children aren't coming to hospital. Families naturally are afraid to come to hospital anyway, and often transport systems are disrupted, even if you don't have lockdowns saying you've got to stay at home. The other thing has been schools. So this is a big effect on kids, and we know that there's reports just this last couple of weeks from both UNICEF and Save the Children talking about 1.5 billion children having missed out on schools during this pandemic, and only about 1/3 having access to remote learning. And currently, there's about 100 million kids out of school from 16 countries across the world. And schools, obviously, as well as learning, are also places of safety for children. There really are concerns, particularly in the poorer countries, that education systems are really suffering because of the COVID pandemic. The other thing which is it can be an issue where schools do open up, and we do see transmission happening in schools, and then kids may bring infections back to their older members of the family. So that in multi-generational households, the child having COVID and bringing it back and infecting the grandmother or whatever can also occur. And there are differences, obviously, between the north, where nearly a quarter of people are over 60 and have had bad COVID, and the south, where that proportion is much less, nearer 5%. But, for example, in Malawi, half the population are under 18, and at the moment there is debates raging about vaccinating children. In this country, you have to think about not only the effects on the individual, where children are at low risk of getting sick from COVID, but also the wider effects on things like education and on transmission of the virus. So those debates are happening at the moment, but as Peter has said, one of the things that's not happening is the vaccine rollout, and it's really a bit of a global disgrace from the north that hasn't happened more. I'm sure we'll talk about that a little bit. There is history repeating itself. As a pediatrician, we fought really hard for ensuring that formulations of medicines for children with HIV became available much more quickly. And we've just finished a clinical trial where really the children are accessing the new drugs, dolutegravir, almost in parallel with the adults. There are voluntary licensing so that generics can make them, and not just one generic. And obviously the same thing is not happening fast enough for the vaccines for COVID, because really, I think it is really excellent that vaccines do seem to be working, even if they don't prevent transmission occurring, which they haven't been doing completely with the Delta variant. But we need to learn some of those lessons from HIV so we don't repeat the mistakes for the less resource well-off countries in the world. So thank you.
Thank you, Di. I think actually you answered my second question already, which was talking about children living with HIV and COVID in Africa and Asia. So I think at this point we'll move on to Dr. Chen Yen Liu, our next panelist, and she is a clinical research physician at the National Institutes of Allergy and Infectious Diseases at the National Institute of Health, and is in HIV reservoirs. And her current research focuses on development of camelid single domain antibodies, or nanobodies, as PET imaging for dynamics application in the National Cancer Institute. So my first question for Chen Yen is, what are the COVID prevention and treatment recommendations for adults living with HIV? And I'll just say my second question now, and then if you want to talk about both of them, it's probably a little bit easier. And the second question is, do people who are immunocompromised have less protection after 2 than other non-immunocompromised people? Thank you.
Hi, everyone, and thanks, Linda, for those questions. Those are linked, as you suggested. I think that the main message, and I'll go into some details in just a second, the main message is that prevention and treatment strategies are very similar for people with and without HIV in terms of COVID. The only difference, which I'll highlight in a moment for prevention, is the possible need for an additional dose of vaccine, of COVID vaccine, during the primary series. So general prevention strategies, just like for people who don't have HIV, include distancing, use of face coverings, like you see me using now, and then the vaccine. Something that I want to highlight, which is not recommended, is use of pre-exposure prophylaxis. So no one should be taking any medications to prevent COVID at this time. We just don't have good evidence for that. Now, in terms of the vaccine question about a possible additional dose, first, let me distinguish between an additional dose and a booster. So an additional dose is given to people who don't respond well to their initial series of vaccinations. The data on that is from the mRNA vaccines, which are given in 2 doses. Currently in the US, the licensed ones are by Moderna and Pfizer. We don't yet have good data for the viral vector vaccine, which is also used, the Johnson & Johnson vaccine, but we do expect that to be coming out soon. So that's for the additional dose. A booster is something different. A booster is for people who have responded to the initial series and then later on, probably 6 months, 8 months, or farther out than that, get an additional dose of vaccination to reinvigorate their immune response. So in terms of the question about who should get an additional dose in their primary series, the answer is a little bit fuzzy because it refers to immunocompromised people. And these recommendations were made by the ACIP and CDC about maybe a month and a half ago or something like that, maybe 2 months ago. And they were based on data that came out from studies in solid organ transplant and hemodialysis patients. What they showed was that if you take the people who have not had a good immune response as measured by antibodies after 2 doses and you give them a 3rd dose, that up to half of those people mount an additional full immune response. So that was really good data. There's additional data that we expect to see on people who didn't even have a good response to that 3rd dose and have a 4th dose. So we'll see what that shows. So the answer to who would need an additional dose is really those people who are immunocompromised with equivalent immunocompromised to solid organ transplant or to hemodialysis. In terms of HIV, that includes people who are not on antiretrovirals or who are not well controlled. So those are people who are severely immunocompromised. For your patient who is very well controlled, has a good CD4 count, and a suppressed viral load, there's no indication right now for an additional dose. Some people have suggested that an additional dose can be decided based on looking at antibody responses and at cellular immune responses. And if you want to talk about that, we can spend more time talking about that another time, but I don't think we need to go into this right here. And then Linda, there was a second part of your question which pertained to treatment. So we've talked about prevention. In terms of treatment, the recommendations from the Department of Health and Human Services guidelines are basically the same for people who have HIV and for people who don't have HIV. Those guidelines are broken down into recommendations for people who are hospitalized and not hospitalized. For the non-hospitalized people who have mild to moderate symptoms, maybe there are antibodies, that monoclonal antibodies that can be used. For hospitalized people, there is a whole hierarchy of what you would administer depending on oxygen needs and severity of disease. And those medications range from the antivirals like remdesivir to steroids like dexamethasone and down to possibly including some of the immunomodulators like agents that work on interleukin-6 or JAK-STAT inhibitors. So those are some of the things we use for treatment. If there are specific questions about that, I can go into the details, but I think the main message is that when you're treating your patients who have HIV, you just treat them the same as patients who don't have HIV. Does that fully answer your questions, or were there any other points that I should cover?
I think that answers my question. So basically, people who are HIV positive are responding to the COVID treatments in similar ways to people who are not HIV positive then. Is that what you're suggesting? So you have the same basically the same treatment regimen because they're responding to it in similar ways?
Well, sort of. So in terms of the treatment, we don't have good studies just for HIV infected people. So we don't have separate recommendations. And from what we've seen, they seem to make a response. But we really do need to tease out that data. And I think in the future, with enough people being infected and treated, you will see more information on that. There has been a suggestion. There's been really conflicting data on this, but in certain subpopulations, they may not do as well regardless of the treatment. So those are, again, in populations that sort of fit into the immunocompromised category, or they have more comorbidities. So they may not do as well, but we don't have better treatment recommendations right now. And in terms of response to vaccine, in general, people with what's equivalent to what we call a functional or almost normal immune system with a CD4 count that's at least above 200, and the higher the better, those people will have almost a normal response to a vaccine. But as people age and as HIV disease gets worse and other things happen, those antibodies do wane, and they may wane, again, we're waiting for more data on this, they may wane more than they would in someone who does not have the same underlying conditions.
Okay. All right. Thank you. Thank you. It's really interesting. All right. So next I want to welcome Dr. Kumar Sami, and he is the Chief and Director of Infectious Diseases Medical Center at Voluntary Health Services Hospital in Chennai. And he directs the clinic which provides medical care for persons with HIV, hepatitis, tuberculosis, COVID-19, and other infectious diseases in Chennai and southern India. He's the director and the site leader for the Chennai antiretroviral site of the U.S. National Institute of Health, which conducts multi-site therapeutics prevention and insight clinical trials. What is the general COVID situation in Asia at the time? And how do you think that people in India who are living with HIV are being impacted by COVID?
Hi, everyone. So at the outset, I'd like to thank Christina and Linda for putting up this panel discussion. And thank you so much for inviting me. So at the outset, I'd like to pay my deepest respects to my very close friend, James Hakeem, whom I consider a legend. We met for the first time in 1999, and since then, for next 2 decades, we did multiple collaborative research through ACTG, HPTN, Insight Networks, through our investigator-driven studies. We trained several young clinicians and across Asia and Africa. We did several policymaking statements for many UN bodies. I miss him. I will miss him. But the legacy, what he left, will continue to follow. With that in the background, thank you for this question on COVID in India. So we are just breathing now. So, I've been involved in HIV care for the last 25 years, and been running one of the largest HIV care program in the country, and the HIV clinical research program, in southern India. So since this pandemic last year, myself and my whole team is moved towards COVID care because that was a need of the hour in India. We had the first case in Jan 2020, who was a medical student who was been studying in Wuhan, who returned back when they started seeing more cases in Wuhan. That was the first diagnosis in India. And since then, the numbers were going like anything. So till last night, we had in India around 33 million people who've been diagnosed with, COVID. And we had around 440,000, deaths. That is very unfortunate in this pandemic. Even now, we have been seeing around 30 to 40,000 new cases a day, 30 to 40,000 even now today, new cases a day, and almost 200 to 300 deaths a day. So we have been doing a lot of testing. So in India, we have facilities to do RT-PCR. We have gene export for COVID, where many of those TB gene export machines are now converted to do COVID testing. We do have this rapid antigen test. So we have done more than 544 million, COVID tests in the country. Almost 380,000 per million, still much lower to our population. So that's what we are able to do. But we have been scaling up. Our everyday tests have been going up, and we test them, found them, link them to treatment, hospitalize them, or isolate them, depending upon the severity of this disease. Many of you would have seen in the media, a few months back, we went through one of the worst second wave, like in many other countries. We have been seeing anything from 200 to 400,000 new cases a day. So we could see all the time, when we come out of our hospitals, only the siren of the ambulance, taking people with COVID. People are so sick, and we had a lot of deaths at that time, almost 4,000 to 5,000 deaths a day. So we ran out of hospital beds. This is in the month of March, April, and May. There are so many sick people, and we had multiple hospitals and huge, beds we have, but still we ran out of that. We ran out of remdesivir, despite it's all been manufactured in our backyard by the generic companies. We ran out of oxygen, people died, you have seen in media. All these we went through, This again, mainly in people who are 65 plus, who had multiple comorbidities and diabetes, and hypertension. Having said this, post-June, the second wave started dipping. But what we saw, another wave was these post-COVID complications, where in the form of fungal infections like mucormycosis. So as many of you know, that use a lot of steroids in managing COVID, particularly in the intensive care in people who are with low saturation to save them. And as well as in diabetics, it can cause profound immunosuppression, where we saw a wave of mucormycosis, such a difficult disease, painful disease, where we need surgical procedures and very expensive antifungal treatment, which we are going through. So hopefully we'll find some answer to that. So when you have been battling it, that's the time India introduced this COVID vaccination program. So to start with, we did first initially among the healthcare workers, then among 65 plus, then 45 plus, and now anyone more than 18, they'll have access to COVID vaccination. In India, we have 4 vaccines or 5 vaccines have been currently been approved by our Indian regulator, but 3 of them have been largely been used. One called Covishield, developed by an Indian company called Serum Institute, which is an AstraZeneca version. And we have an indigenously developed vaccine called Covaxin, which is a killed vaccine, developed by an Indian company called Bharat Biotech. Of course, we do have these Russian Sputnik used in very small numbers. And very recently, Moderna is being approved for use in India. It's been marketed by another generic company, Cipla, but still not in the market yet. And also, we do have a DNA-based vaccine very recently approved, which was indigenously developed by one of our Indian companies called Sycovi, which has also been approved for more than 12 years in my country, and it is subcutaneous in 3 doses. So these are the various vaccines, and we do have several other things in pipeline, J&J, Novavax, and all being under by regulators. Maximum in use is Covishield, AstraZeneca version of Indian one, and Covaxin. So till yesterday, we have 750 million doses had been given, and out of those 570 million first doses, that is 42% of Indian eligible population, 18%, has been vaccinated. Now I feel proud to say that, because a couple of months back, we have been battling with just 10%. I was being issued by all the media, hey, what the hell you have been doing in India? But now we have gone that in the last 2 months, thanks to the efforts by our public health program and our national government, we are into 42%. And coming to the 2 doses, fully vaccinated, we have around 180 million, almost 13%, 1-3, which is just low. Now, again, in India, we can't do this in one day because of a large population, 1.3 billion. I think, it will take middle of next year, to want vaccinated. But we want to do it by this December. but may not be possible. We have a big festival coming up called Diwali. So we have set up a target to vaccinate as much as people so that people can go out, enjoy this festival. So we have been done a lot in terms of vaccination in the last couple of months. Next to China, probably India has done the maximum doses. In fact, including we have done more than the United States, but our population denominator is huge. Now, coming to those main question on HIV, which a lot of all our life we worked on that. In India, we have 2.1 million people living with HIV, and we have free access to antiretroviral drug, thanks to the Indian generic manufacturers, and we do have appropriate guidance to do that. So what we have done is seen in the context of COVID and HIV-infected people. In fact, myself and the group have done a review article, a few months back. Some of you have seen where we reviewed all the literature published across both in developed and developing countries, and very clearly said HIV itself will not be a risk factor. Only the other factors like CD4 cell count, HIV viremia, disruption of antiretroviral therapy, and other comorbidities which our HIV-infected people go through. So we did a research in my own cohort, which we have been following. We follow a cohort of 20,000 people living with HIV. And in this last 1.5 years, we have seen almost around 165 people in that being infected with COVID. The numbers are very little, but this is because they are symptomatic. We did a testing. We do not know there are so many people, would have been infected, they would not have been tested. And again, what we have seen that in this particular group of HIV-infected people with COVID is people who have got a good CD4, suppressed viral load, who are taking antiretroviral therapy, they are perfectly fine, like any other non-HIV-infected people. But people who had disrupted antiretroviral therapy, which had happened because during these COVID times, people couldn't move out of their homes. We had huge lockdowns, a lot of restrictions in travels, so they couldn't come to the pharmacies to refill, couldn't come to the doctors. So we did a lot of other things to manage at that time, doing telecounseling, video counseling, couriering the medicines to them. We did multi-month prescriptions and all those we did. So only people who couldn't afford to take these antiretroviral drugs, we were able to see some major morbidity and mortality. Also, the major mortality of COVID happened in HIV-infected people is people who had other comorbidities like diabetes and hypertension. So that means HIV itself is not a major cofactor. That's what we found in our own research in our hospital at Medical Services Infectious Disease Medical Center. So paper is now getting published, but on the other hand, other comorbidities. So the take-home message we gave to a lot of clinicians and as well as to our own community of people living with HIV is, along with other public health message of masking and hand washing and physical distance, take your ART properly. Take your OA drugs properly, take your TB medicines properly, and please control your comorbid condition like diabetes and hypertension. And of course, we also vaccinated them. Now we have done 2 doses for people living with HIV, but we have been waiting for more guidance from the developed world, from CDC, whether do we need to give another booster shot and when to do this, especially in the context of this immunosuppression. So at this time, I'll stop and happy to answer more questions. And again, thank you so much for this opportunity.
Just realized I'm muted. Thank you so much, Kumar. So it's interesting then what you're saying is that the real issue for people who are HIV positive is that they have other comorbidities that complicate COVID just like they do for people who are not HIV positive. And in addition, the COVID epidemic is keeping people from accessing their normal HIV care. They're not getting access to their meds and so forth because of lockdowns. And so it's more about that than about how COVID impacts them physiologically. So that's really quite interesting. So, well, I will let some of the people in the audience later on ask some more questions about that. And I am going to now move on to our next speaker, who is Elly Vaughan. And she is an associate in health policy and clinical evidence at the Economist Intelligence Unit, which is part of the Economist magazines. They have a big research organization called the Intelligence Unit. And so she focuses on the Economist Intelligence Unit just finished a big study that's focused on disparities in healthcare related to COVID-19 and HIV, and some other things as well, but that's the part we want to focus on. So Elly, we've heard about some of the parallels between HIV and COVID-19. So we wanted to know why you wanted to look at health disparities specifically, and what from this big study, what findings do you think were particularly pertinent for our audience to hear today related to that issue?
Well, thanks so much, Linda and Christina, for inviting me. I'm really honoured to be part of this esteemed panel in remembrance of James Hakeem, who I was not lucky enough to have met. So I'm going to give a quick overview of a project that we've been working on for several months now, and that will be published on our website in the next few weeks. So thinking about health disparities, from the outset of this project, we always set out to look at health disparities. But one of the things that struck us really early on in our research was actually the huge impact of health disparities globally. This isn't a niche issue. Rather, it's something that costs billions of dollars, reduces the quality of life, causes premature death, disability for millions of people. You know, we put it in our report, disparities in care are avoidable, unfair, and cost us all. So we were really struck by the very urgent moral, social, and economic impetus for action. But we're equally surprised by how little progress has been made despite various efforts. And this was something that we specifically wanted to address in our research. So we also realised that health disparities are present globally and in all areas of healthcare. So we did need to think about focusing that down somehow. So we've heard from Peter and Di about the historical global disparities in access to HIV treatment and now to COVID vaccines as well. But in this research, what we did was to focus on disparities within countries. So we looked in particular at the UK and the US. And the reason we chose these two countries was because they have such fundamental differences in how their health systems are set up, yet we see very similar patterns of disparities across the two. And similarly, we looked at, as Linda mentioned briefly, we looked at COVID-19, HIV and STIs, and mental health as three topic areas. And that's because we thought that COVID-19 had really brought to prominence health disparities. So it had shone a light on this ongoing and very long-standing problem to a sort of wider audience than perhaps had been aware of it before. But we also wanted to show that disparities are present across a lot of different areas of health. And this way we felt that actually we would strengthen our argument in HIV and all the other conditions that we wanted to look at, because we didn't want it to be dismissed as just an HIV problem or something like that, but showing how the health disparities that have a profound impact on people with HIV also manifest in other areas of health, affecting people's overall health, their quality of life, etc. We felt that that meant that our research has applicability far beyond the two countries and the three health areas that we focused on in the research. So in thinking about what's most relevant to the audience today, in our research, we looked at three scenarios that we put together around achieving health equity by 2040. And one of those focused on ending the global HIV epidemic. And in these scenarios, what we did was we looked not only at the direct benefits, so for example, preventing new HIV acquisitions, but we also looked at some of the indirect benefits. So the opportunities that we could create through achieving health equity. So in the case of HIV, if we're able to prevent newly acquired HIV, then where could we put the money that we would have spent on those treatments and reinvest it elsewhere? So some things that surprised us in our findings, which may not surprise the audience, were just how much health systems tend to be incentivized to maintain the status quo. And that makes it really difficult to achieve change. And another thing that we came across was the need to think about who your stakeholders are and how you engage with them. Because in the course of the research, we discovered what was a new to us category of validators who are, really key stakeholders in HIV as sort of trustworthy bridges between health institutions and communities who have often been marginalised or may have mistrust in medical institutions for historical and current very justified reasons. So to sort of bring it to a close, one of the problems when talking about health disparities is that sometimes it's framed as an intractable issue and there's no real clear sense of where to start with tackling it. And as I mentioned, we were very keen to make sure that this research was actionable. So in our report, what we've done is we've identified an entire ecosystem of stakeholders, including validators, as I just mentioned. And this ecosystem of stakeholders can all work together to deliver this shared vision of health equity. And we took this one step further by then attributing specific actions that these stakeholders can take to help to get towards that vision of health equity. Because what we wanted to do there was to give direction and also accountability. And what we really hope with this research is that we can support a greater focus on equity-centred performance and targets, and that we can help to enable stakeholders and systems to both reduce disparities, but also achieve efficiency and other potential opportunities and gains in both HIV and beyond. So I'll hand back over to you, Linda, and happy to take any questions.
Thank you, Elly. Actually, I'm really excited to hear your response because it sounds like what you're saying is that there needs to be both top down and bottom up. In other words, we need to mobilize the entire community and we need to figure out how to mobilize key opinion leaders and get different communities involved so that it becomes theirs and they help mobilize and move things along. So that's really interesting. I look forward to that report coming out in a few weeks, and I assume we will look for that on the website of The Economist or the Economist Intelligence Unit. So great. Okay, so now what I want to do is shift the format and open up the discussion to all of our panelists. So I think we have 5 panelists with us today, and if they all want to turn on their cameras and their microphones, then we can turn to, I have 2 questions. The first one is, given that COVID is not going away anytime soon, or doesn't seem like it is, what do you think we should do to move forward with HIV care in the current COVID context in a way that is equitable? So how do we move forward with HIV care in the current COVID context? And so I'm not sure who wants to speak to that first. Oh, I see Kumar has his hand up.
Sure. I think I will start. Might be my other colleagues will finish it up. So I think, being a clinician, being involved in HIV care, similar like Peter and Di and others in this audience. So I think we learned so much in managing HIV in the last 2.5 decades. And also we learned very well that antiretroviral therapy saves lives and prevents transmission. So I think now this is time that how we can take those learnings into this COVID management, and as well as the learnings from in the last 2 waves of this COVID morbidity, how we can translate into those HIV care to prevent COVID complication. I think that's something what we need to concentrate at this time. One of the great learning we have found in that is, so if we manage HIV very well, they live like a normal people. It's yet another chronic manageable disease. And today, my patients, many of them on antiretroviral therapy, no one will tell them they are patients. And they have been normal persons. They just say, come, hey, hello, and we just tell them to come every 6 months to do CD4 viral load and collect medications. So, but on the other hand, if they're not doing that, that could be a major risk factor for COVID disease progression. I think, what we should do is, what we are doing currently in HIV, we should emphasize again and again. COVID can be there. It's not going to go away. It might be there next 1 year or 2 years, or with the current vaccine, we are seeing, again, breakthrough infections. And it might be there forever. It could be like another influenza. So we may have to live with this. But on the other hand, how we can protect our HIV community? I think, take their ARVs well, make sure that their comorbid conditions are taken care very well, but along with other public health messages, we give it to this COVID. But on the other hand, we should vaccinate them. I think we should give a lot of priority to our HIV community for vaccination. So we should not keep them away. Vaccinate only those elderly and other risky groups. I think we should give a lot of importance how we give pneumococcal vaccines to our HIV-infected people. We gave trimоxal prophylaxis earlier to prevent PCP. And I think similarly now, this COVID vaccination should be given a top priority. And also, as a group, we should emphasize what type of research questions we need to develop to work on them, particularly in the field of vaccination. Do they need multiple booster shots? Or probably they may need different vaccines. I think that type of things, we need to, work on. So I think at this time I'll stop and, pass on to my next panelist.
I'd like to chime in there. Those are really excellent points, and I think this is an important question that we've all been grappling with. I totally agree with research. Of course, I'm biased there, so I totally agree with research on vaccines and also on other strategies. Research sometimes provides access to medications and vaccines and other pharmaceuticals when other supply chains are interrupted. So that is something that should be considered also, though it's not a very broadly scalable strategy. Another thing that we've been using here is where patients have the capability is using more telehealth and phone visits. I've found that with my patients, particularly those who are well controlled, if I can have them do their laboratory studies remotely, I can send them a kit, have them go to the lab, and then I can get the results, talk to them by phone or by an online kind of telehealth visit and actually see them, that we can take care of most of their issues with the anticipation that they will eventually return in person. And I've found that to be a very, very helpful bridging strategy. I think that the patients actually like that too, and they feel very comfortable. We counsel them on that if they do need to be seen, just to make sure they have adequate precautions in place and to protect themselves and others. The other thing that has arisen in terms of these disruptions is prevention has taken a hit. And I think access to PrEP, especially pre-exposure prophylaxis for HIV. Now, this is different than what I mentioned about COVID, PrEP for COVID, but the access to pre-exposure prophylaxis for HIV has been harder for many of our patients to come by. I know that at our county health clinics, we've really limited the number of inpatient visits and also the less acute, PrEP kind of visits, and that's being provided remotely. Another thing that the research can help with is the role of longer acting agents in HIV care. Now that we don't see people as often, they may not have access to as many services. So there are injectables that are longer acting and can be given, monthly, and eventually we hope that they can be given every 6 months or a year, like the new cabotegravir or rilpivirine kind of combination. And those would really be sort of game changing, not just for treatment during pandemics, but also for populations that are marginalized and can't come in or say, women who don't have control over, you know, their own lives, or people who don't want to take pills every day. So I think those are some strategies that need more exploration.
Right, right. Like people who don't have easy access to care, then needing less, you know, needing to get there less often is removes a huge barrier. So I saw that Peter had his hand up. Did you still have something you wanted to say, Peter?
Yes, I just wanted to endorse what Dr. Kumar Sami presented. Wanted to add that stigma is still an issue in some of the people living with HIV. And issues have been raised concerning special passes for them during lockdowns, that if they are given special passes to go and access their treatment, that might be interfering with their privacy. So sensitivities in handling people living with HIV during the COVID lockdowns is very, very important. One of the methods that has been used is to use the volunteers, most of them themselves living with HIV, to deliver the medicines to people living with HIV in their own homes. This has helped a little bit. Then, of course, the last point made by Liu Chen, very, very important indeed. That is long-term medications, long-acting antiretroviral therapy. But currently, in areas where HIV is most prevalent, these drugs are just not available. However, what Dr. Kumar Sami said was to give them treatment for a longer term. The practice was usually to give them treatment for 3 months. Perhaps we could give them medicines for 6 months or 4 months so that they don't break adherence. As indeed the aim of, the key to success of antiretroviral therapy is adherence. And adherence cannot be achieved if they don't have access to drugs so that they are consistent. So those are a few points that I just wanted to add on to good points already made. Thank you.
Thank you, Peter. I think the issues of access and adherence are paramount, and maybe we'll come back to that in a couple of minutes when we talk about vaccine access. So, all right, so Elly and Di both wanted to also comment on this question. I think I saw Elly's hand first, so we'll let her respond next, please.
Thanks. So I can only speak from the perspective of a researcher. I'm not a clinician working in HIV, so I have to caveat what I'm about to say with that. But I've done quite a lot of research that's obviously been touched by COVID now. So, you're seeing patterns across not just HIV, but across lots of other health conditions as well. But in HIV, it's been severely affected by COVID in terms of things like we found that 1 in 5 people with HIV in the US reported that they'd missed a scheduled appointment in the previous 30 days, and 45% of them cited COVID as the cause. And in the UK, we've already seen testing rates fall by 35%, both things that could have huge impacts, not just on people's health if they do unfortunately get COVID, but also on their long-term HIV status and viral suppression, etc. And I think one of the things we need to think about is moving to this more long-term sort of thinking. So not necessarily looking to our new normal or our post-COVID world, but actually thinking about how do we proceed with HIV diagnostics, prevention, treatment in a world where we are having to live with COVID and we don't know how long that will continue. So Chen Yen mentioned telehealth and remote care earlier, and I think that's something where it would be really great to think about the opportunities that we can create there, and also how and where we can translate the sort of temporary workarounds that we've put into place into permanent changes to service delivery. So really thinking about the opportunities that we might have, especially where things like telehealth have been sort of long thought of as too difficult and too complicated, etc. But also I would caveat that with any sort of move towards, virtual health, things like that, has to obviously consider access issues and the digital divide and things like that. So thank you.
Yeah, I mean, those are issues like the digital divide are huge issues in terms of access and inequality. So thank you for raising that. So now I'm going to turn to Di and let her have the last comment on this question, and then we can move to the next one.
Sorry, I won't repeat what other people have already said, but just a couple of comments, really. I mean, we've been continuing to do treatment studies in various African countries during COVID in children. And so this obviously involves families. So some of the things that Chuen-yen and both Elly have also talked about of trying to do things more remotely and more delivering medicines locally, etc. I've been really impressed with how people have tried and succeeded in doing that. But obviously the digital divide is a big issue when you're talking outside the research situation. I mean, I think there have been some pluses with Zoom being available everywhere in terms of learning things and joining our sort of many research activities, that it's been possible to continue to do some of those things. There were two populations I wanted to just highlight. One is pregnant women and diagnosis of HIV during pregnancy. And in fact, with our Zimbabwean colleagues in Ministry of Health and Angela Mishavi, we've been looking at the impacts both in terms of pregnant women and newborns of COVID and access to antiretroviral therapy during pregnancy, because that's obviously a time-limited and important area where women coming up is important. And I guess the other one, which James was involved as a investigator on and was the lead first author on, was a study we did called the reality trial of late presentations. And late presentations continue to happen in HIV, particularly in the African countries, and for many, many reasons. And obviously COVID is going to make this worse. So these are undiagnosed people who, are not going to come forward so quickly for diagnosis. And that's very important to think about. I think mental health for adolescents, when we're talking about vertically infected children, then the successes, which have been thwarted somewhat by COVID, we've already got data on that, of preventing mother-to-child transmission, mean the number of young children has decreased. But we've got a large number of adolescents with HIV who've survived because of antiretroviral therapy, now going into adolescence and adulthood. And we know that mental health for adolescents throughout this pandemic has been really quite severely affected. So those are some of the things. And I think we'll come to issues around COVID vaccine research a bit later on. I'm really thinking about the strategic aspects and the importance of doing studies, maybe a bit like the DART trial, Peter, where you're thinking about the strategies for vaccinating in Africa. And obviously with you and other colleagues in Africa, we've been thinking about this. Quite difficult to get the world's attention on it, I think. Thank you.
Thank you. So you're raising some really important questions about how different comorbidities, how these things interact, how COVID affects them, how it, escalates them perhaps and ramps them up. So several people actually throughout this webinar have alluded to this major ethical question that we really must address, which is whether booster shots should be given in higher income countries, while so many people in lower income countries haven't yet had access to even a first dose of the vaccine. And so I was hoping that you would each comment on this. And it looks like Elly has her hand up already. She definitely wants to comment. So Elly, why don't I turn it over to you first?
That was actually left over from the previous question. I wasn't quite as keen as you thought there, Linda, but I'm very happy to go first. I think I would just say that the emergence of variants around the world has shown that the value of prevention efforts, and vaccines are a very real and very central part of this, especially where some other non-pharmaceutical measures are not seen as particularly sustainable and things like that. And I think also many other commentators have highlighted that a global approach is needed, and variations on the theme of until we're all protected, none of us are protected, etc. So I think for my perspective, it's something that's very important to keep considering. And also, as someone with a background in evidence-based research, I would always say that we need to continue to gather research on the effectiveness and the need for booster shots, while we still have so many people who are either unprotected or underprotected.
Absolutely. Do any of the other, looks like Di would like to speak next.
Yes, thank you very much. Yes, it's an interesting question, and there was a recent WHO webinar about it in terms of the evidence of what might be needed in terms of boosters. We know that antibodies wane after vaccination, but that's known, very well known, in many diseases, and I'm sure Lau will be able to say more about that. But we do have quite a lot of ongoing questions, really, even as to what dose you might need of some of the different vaccines so that you could use them more efficiently. I mean, clearly in some parts of Africa and in some cities, for example, the seroprevalence is really quite high, with quite a lot of people young people, I think, having had fairly asymptomatic COVID infection. So what we've done in the north and in most countries, I think, is just roll out vaccines to everyone. But if you've got 50% of people in Blantyre who've got antibodies who've had COVID, surely you should be prioritizing those who haven't had a vaccine. And everyone said that's too difficult, but I think that needs research. I think you need to think about the strategies for countries that have got younger populations, that where you may have already got quite a lot of natural or infection having happened, and there are point of care antibody tests. Everyone said that's too difficult to do, but in organizing vaccination programs, which Africa's been so good at doing for children, why can't we look at those kind of questions? And also what kind of doses we need when you're short supplies and you need to do it quickly, and the waves are coming there. And the other thing, obviously, is addressing vaccine hesitancy and a research on the ground which has all these factors in there, and thinking about best ways of communicating, which is obviously key. And we've learnt that or seen that really in the Ebola epidemic, also very important aspects. Thank you.
Thank you.
Thank you. It's very interesting, important considerations. And so now I want to turn to Kumar.
Right. Thank you. So I think this is a very important question, especially on the booster doses whether we prioritize to people living with HIV. So today, with the scientific advances and also advocacy, and also with the political commitments, today we are able to get all these antiretroviral drugs for our people living with HIV, even in the poorest countries, where we have access. And thereby, we made this disease, yet another chronic manageable disease. I still remember those battle days, way back in the year 95, 96, before we had antiretroviral therapy. We used to have like 5 to 10 deaths a day in our hospitals with HIV. But today we hardly see anything. Similarly, people come with HIV, with TB, and crypto, but we don't see them with the antiretroviral therapy. So we have done a lot to do that. Now, having said that, now this is time that whatever learnings from science, which will help our HIV-infected people in the context of COVID, I think we should get them as soon as possible to them. If we don't do that, whatever good efforts we have done in getting them tested, link them to treatment, put them on antiretroviral drug, all will go as a wasted. So I think this is that how we are going to do this to our people living with HIV is important. Again, having said that, 90% of the people living with HIV, they are in the lower and middle income countries. But all those booster shots and the super booster shot people are talking about, the research is I think it's up to us, we clinicians practicing in developing countries, we policymakers, and how we gel with our political leaders to get this access to our people living with HIV with the best science available. I think that's important. That's something what we should work closely with our HIV community.
Yeah, I think that's a very important point. And next time we plan a webinar, we should really think about how we can get maybe somebody with a policy.
You mean like Elly?
From that perspective. Yes, like Elly and her more as kind of data researchy than the policy side, but you're right, her data is policy oriented. Let me turn to Chen Yen now and let her comment on this issue of access to booster shots versus access in low-income countries.
Yeah, I think this is a really tough one. As someone who sees patients in a less resource restricted situation, I would be really curious to hear what people here might tell someone who has access to a booster and thinks they might have benefit from that. I really don't have an answer to that, and I don't know what to say to those people, because it totally makes sense that we need to have people who are not vaccinated, who are under-vaccinated or under-protected, get priority in terms of accessing those resources. However, when the resources are available or have been made available and people can get those, it's very, very difficult to advise them not to access those resources and to counsel them otherwise. I have yet to have the first patient ask me if they should get, not ask me, actually go for a booster. I have had some get additional doses because they are immunocompromised, and that's sort of an easy one to answer. But the question of boosters is just, it has presented quite a quandary. And it's not just the question of whether someone should get a booster, it's which booster should someone get. Right now, the EUAs, are related to, or the recommendations are related to getting the same homologous product and to getting it at least 4 weeks later. And they're only relevant right now to the mRNA products for us. However, there are a lot of questions about mixed or heterologous vaccine series and whether those might provide better protection or worse protection, as some studies have suggested. There's also the question of dosing. And then there's the question of whether vaccine formulations are going to be modified with emerging variants. So these are all things that have to be thrown into the mix of considerations when deciding when and if someone should get a booster. Now, that being said, I do have a number of people who have come to me and just notified me that they've already gotten the booster and that they just signed the forms and they got it. It's relatively easy to access these boosters. People just have to sign that they're immunocompromised or that they need it for some reason, or may not have to give any kind of disclosure, and they just provide their signature, and it's left to their judgment. In fact, there may be lines on these forms that say, you know, if you state such and such, we will not give you the vaccine. And so people are, like, in a sense, advised what to write. So people just come in and inform me, oh yeah, I got my booster, or I got an additional dose, or, you know, they'll come up with those statements. But I would really be interested in hearing what others would tell someone who has access and you know, wants to know if they should get it.
You know, I just wanted to follow up, Chen Yen, on something you said about the mixing of different vaccines. And I live in Germany right now, and they were rolling out the AstraZeneca there in the beginning, and then, you know, some warnings came out, and they decided that it should only be available for people who are under a certain age, and I don't remember what that age was. Maybe it was 55. And so I had some friends who were older than that age who had already had their first shot, who were then advised to have the Pfizer BioNTech as their second shot. So there should be some data. See, of course, who knows if this is being tracked by researchers, but there should be some data coming out.
That data is available, actually.
It is?
There are several studies that have published that data, not just from Germany or Europe, but also there's the big Spanish cohort from which that data is available. There were comparisons of, and of course, and yes, this was just in population, I think it was over 60, but different countries had different recommendations. And it was because of the clotting events that were occurring in younger reproductive age females. But there was data on just AstraZeneca alone versus AstraZeneca followed by the Pfizer BioNTech versus homologous Pfizer BioNTech. And you know, that data is based on immunogenicity by antibody response. That's what those studies looked at. Some people would say that that's not the only response you should be measuring, that you should be measuring a cellular immune response too. But when they looked at antibody responses, the homologous Pfizer BioNTech mRNA product actually performed superior to either the heterologous AstraZeneca followed by Pfizer and BioNTech, or I think vice versa even, and also superior to just AstraZeneca alone. And that was in terms of an antibody titer response. The cellular immunogenicity has been very mixed on those, and the question about what matters long term has not really been settled. Some people would say, oh, even if your antibody response wanes because of the anamnestic response or the response when you get a follow-up exposure, that's okay because you'll mount a quicker response. But you know, there's also the camp that says, oh, you need really good cellular immunity. I think there are still questions about that. Though, as you mentioned, that data is becoming available. And that's short-term data. I think most of the data that's available is for follow-up up to maybe 8 or 16 weeks. We're waiting for longer-term, like 48 and 96-week data, I think.
Okay. Interesting. So I want to turn last to Di, who has patiently had her hand up.
Just to jump in on that one a little bit, because certainly the Oxford randomized trial, which was looking at those different mixtures, suggested that AstraZeneca followed by Pfizer was actually superior. So you know, that I think people are still a little bit out there, but certainly in the UK they're thinking of giving a different booster. But just to come back to that question you asked about, you know, should you ethically be giving boosters while the rest of the world or many other countries haven't got anything? And I think some of the statistics are rather startling. I think 80% of vaccines are being given to about 5 countries, and that pre-ordering is a big thing. I think we've pre-ordered, you know, something like 6 vaccines per person in the UK. Canada's done 9, or these kind of things where there is still a shortage needs to be sorted out at a, you know, in a global and fair way. And I know various people from WHO have, David Nabarro, for example, was jumping up and down about vaccines going out of date in some countries and not being available in many others. And this is just terrible, really. But I do think that, you know, when you're talking about boosters, I mean, for example, the Pfizer, with its cold chain requirements, is not necessarily going to be something that you can transport to villages across Africa. And so there is a need with all the vaccines that are out there for some sort of, and I think COVAX has tried, but acquiring vaccines was difficult. I think they relied really on, you know, one generic from India, and of course India, then you had your big wave, and really the Serum Institute could not supply to other places. So this just needs to be sorted out quite fast, I think, as well as, you know, the sort of research on the logistics and the practicalities of how you get people vaccinated fast and efficiently, and possibly, you know, using those sort of approaches that I just mentioned. So I think the two of them aren't necessarily mutually exclusive if you're thinking about what kind of vaccines are best used where. Thank you.
Thank you. You know, I really hate to wrap up this discussion. We all have a lot of great experience and insights into this whole issue, but we are already opened up the floor yet for audience. And so at this point, I'm not sure how many of our audience members are still on, but if anybody has a question they want to pop it into the chat function, we can quickly address those.
Where is Zach? Maybe. I think on mine I can show the conversation. Oh, I just lost access to the chat, so Oops.
I'm not a member of the chat.
I have a question. Where's my hand?
All right, Christina.
There's a question from Corrine. I can read it here. It's in the chat box.
Okay, I can't see it, so that'd be great if you'd read it.
Let me turn this chat meeting off and see if it's easier for you to read what they've got.
Okay, while you're doing that, I'll just read this. Maybe it's a comment. The health disparities are very real since the vaccination programs are outside of existing systems. In many ways, they may lend themselves to being the place to introduce changes or improvements in systems that don't like to change. Would layering simple, easy things into the vaccine outreach, like hypertension or diabetes screening, HIV, TB testing, providing referral services for other services at the clinic, for other medical care, housing or food needs, or other more imaginative ways to use the vaccination machine, shift healthcare systems?
It's a great question. Does anyone want to answer that?
Okay.
Well, I mean, oh, Christina, you had your hand up, or Peter, you have your hand up, so go ahead. I can make some comments after you.
No, I was going to I actually had it up earlier. I was going to ask a question of Elly, but since you've read the question from the audience, if you have a response, please go ahead.
Sure. I do think that other points of care for other diseases are a great entry point also for vaccination. So it's kind of like what we do with HIV testing. If someone comes in for something, they should have an HIV test at least once in their life, and then more frequently depending on risk factors. So with COVID vaccines, for people coming in for any type of healthcare, it would be reasonable to ask them if they've been vaccinated and get their vaccination history, and then if not, to offer them the vaccine. I think this is a very logical way to do things. And also, because people are coming in for other diseases, these are people with comorbidities and likely at higher risk. The hypertension and diabetes are mentioned here. Those probably run also with things like obesity and metabolic disorders. Those would put people at high risk for COVID complications if they were to get infected. So I definitely agree that any healthcare visit should be an opportunity to engage in vaccination discussions and referral for vaccination.
Unknown caller.
And for other vaccines as well. For example, once we start vaccinating younger teens, we can talk about the HPV vaccine and so on and so forth. So there's a lot of opportunity there, I think.
Yeah, absolutely. So, an opportunity for integration, and that's what we're really getting at, is that a person doesn't need to be just treated for one thing at one point in time, like in a little siloed or compartmentalized way. They need coordinated care, and there's that concept of medical home or, multidisciplinary care. And this kind of COVID vaccination strategy just gets at that issue, is that people's care needs to be coordinated to be not just efficient, but also most effective.
Yeah, absolutely. Absolutely. Di, did you want to add to that?
Yeah, I found it quite interesting, actually, hearing about your story from the US of people going out and getting a booster. Now, you wouldn't be able to do that in the UK. No way. You get your, because they've organized it on a whole population basis, and you get called when when the next age group goes in, or you've got particularly morbidities, etc. And so there is a difference between ensuring that it's the same as when we do clinics, we don't tend to say, right, we're going to give the children their vaccines if they've missed them necessarily in that clinic there. So that it's about thinking about the strategies, obviously raising things, and then thinking about referral patterns is really important. But to be highly efficient with vaccinating, I mean, it was interesting. We had our test and trace system really taken over a little bit by the private system, and it's been rather expensive and not necessarily very successful. It's cost a lot of money, and it's not as local as it should be. Whereas I think our public health people said, over our dead bodies, are you going to have privatizing of doing the vaccine rollout? The NHS is very good at it. And volunteers, of course, have been a major part of local efforts. In the middle of, Dartmoor, the village all turned out, became a vaccination centre because they had an enormous hall and were extremely efficient at getting through the numbers. So, I think that obviously people have got to think about the best way of doing these things. But I do think there's an opportunity where, you've got long-term care of, for example, people with HIV, and you've got really good trust between HIV providers to think about whether families, I don't know what Peter thinks about this, but, actually it would be an opportunity also to study the whole issue about vaccinating people with HIV who've often got much lower immunity than we see in the north, and where things may be a little bit different. And you could say the same about people who've got TB or other chronic diseases, that it's important to do those studies, and building on that to think about the implementation. And I agree with you, Christina, or whoever it was that said, actually having policy folk, when we were discussing some of these, the policy folk from Malawi were just fantastic at thinking about how they might do these things. It's not really, I don't think they've even had the opportunity to do it all yet because they've had so little vaccine.
Unmute. Let me turn to Elly now. Thank you, Di. Turn to Elly now.
Go for 4 minutes over if everybody would like to stay.
Okay, I will keep it brief. Essentially, just to echo what Chen Yen and Di have been saying, I myself as a researcher have been talking about integrated care for far longer than I'd like to dwell on. And I think here again, a bit like we were talking about the opportunities for telehealth earlier, and actually exactly as the audience member highlighted, we've got an opportunity to think again about how we look at organising our health systems and how we organise how we deliver care and things like that. And for example, I've done a lot of work in various non-communicable diseases and trying to raise awareness, etc. And actually, a lot of the time, it's not always worth trying to get busy general practitioners and family medicine doctors to try to learn about every single possible condition, but actually thinking about how can we clump together batteries of tests so that you can get these things done really efficiently and effectively. And I think that's where this idea of sort of trying to have a more integrated, person-centered and less disease-centric approach could be a real opportunity to rise out of this sort of new ways of thinking that COVID is forcing us into. So thank you.
Are there any other comments from our panel about these issues or any? I can't see the chat, so I don't know if there are any more questions on the chat.
I don't see any more questions.
No, our guests are leaving in droves.
Okay. Okay, Elly, do you still have your hand up, or is that from before?
That's from before.
Okay. All right. Well, then at this.
Okay. Well, I'm going to take it from here. All right. So I wanted to just take a moment to express.
This was really.
Okay. I don't know if anybody can hear me or not.
Yes.
Okay, great.
Yeah.
Thanks. I really just want to take a moment to, express my thanks and gratitude to everyone here today, and to acknowledge and recognize the Uganda National Academy of Sciences, Picturing Health, that did our video with Dr. James Hakeem. At least they did the interview and we did the other parts, and our editor, and the Economist Intelligence Unit. Thank you very much for joining us, Elly. It was so good to catch that study right when it came out. I'd like to also express our appreciation to our board members, starting with Dr. Peter Magini, who he and I really worked very hard to pull this together, and we're giving Lewis a little credit here. Lewis Grew, who also is a member of our board, Jabin Sharma, Marcia Green, who's also on, and our moderator and board member, Dr. Linda Sagristano.